So we now move to the last session of this conference, the status of cardiac services in India during the COVID pandemic, to be taken up by Dr. Kunal Sarkar. And to chair the session, may I request Dr. Anjanlal Datta to chair with Dr. Jyotirmoy Pal?
Okay.
Thank you.
Yeah. Dr. Kunal Sarkar is just not a renowned cardiac surgeon in India or abroad, but his face is very much well known in India as one who is highlighting different aspects of COVID from the social and medical point of view. Dr. Kunal Sarkar has been with COVID, highlighting, looking into the different aspects, problems in Indian scenario. And I hope that his narrations about this particular topic would throw new lights and help us get more apprised with the problem. Dr. Sarkar, please.
Anjanda, thank you so much. And thank you to Dr. Guho Shantanuda for giving us an opportunity. And I think it is always left to the surgeon to bring the bad news to the table. My deliberations or I'll try to share with you something which is primarily more economic than clinical, because all of you over the past 2 days, I see in the agenda, have had a very thorough and very stimulating clinical discussions. Let us have a glimpse of the world as it is in terms of interventional cardiology and cardiac surgery. The global situation when we left the world in its normal state somewhere in January of, say, 2019, of 2020 rather, the world that is stood did about 1 million cardiac surgeries and about 7 million cardiac interventions. And out of the total 8 million cardiac procedures, the growth rate annually used to be 5% per year. And the growth rate in the interventional domain was primarily fueled through TAVR in Europe and North America. Coronary surgery, it was growing, especially in the Asia, and thanks to India, somewhere in 0 to 2% per year. And interventions, PCI did have a recorded growth of 3 to 5%. This is a rough state of the world. This is all true of sort of January 2019, January, February time. And Asia Pacific is the main theater of growth as far as cardiac procedures and interventions. But this growth was expected to plateau in 2 years. That is much before, these predictions were made much before the arrival of COVID. And let's see what happens after that. In India, we identified the time around 2006 or 2007 when interventions overtook surgery significantly. And by a thumb rule estimate, all of us know that we do not have very comprehensive data collection in our country. But the cardiac surgery numbers in India stand somewhere around 210,000. And I think the lab intervention stands somewhere around 800,000. Coronary bypass, as far as surgery is concerned, is around 50%. Cardiology, interventional cardiology, if you go to the industry and economic assessments given by various economic forums, out of the 8 lakh or 800,000 procedures done annually, we were still growing. We were growing at 5 to 8% per annum. And around 700 odd centers had 1,200 to 1,300 cath labs. So India's growth rate in intervention, both in terms of the facilities and in terms of the number of cath labs, was definitely impressive. I think one of the highest growth rates in the Asia Pacific region. What I think is, again, number-wise, it thumps the table, which is we have a rough estimate. I don't think you know for yourself either, that cardiologists are supposed to be 4,000 to 5,000. In India, about 350 to 400 are added per year. And with the prolific increase in the number of postgraduate seats, it is perhaps foreseen that we may add up to 500 plus cardiology postgraduates annually. I think that is probably in the pipeline. And therein lies a danger. Before we come to the effect of COVID on the business and the procedures, I think in the very near future, with or without COVID, and more so with COVID, I think we are already in a situation where we are seeing a cardiological oversupply because the number of undergraduate and the postgraduate production in India is increasing exponentially. But I will refer to the slide a little later on. This is something I've discussed in my recently published book at length, that the healthcare infrastructure is not really increasing in keeping with the healthcare personnel. Well, cardiac surgeons, honestly, have been limited because cardiac number of cardiac surgeons have been stagnant. We have not populated our postgraduate seats the way we should do because goes without saying, you know the reasons why, that cardiac surgery does not have a queue of entrants, unlike cardiology. And at a conservative estimate, we have about 30% vacancy in CTVS postgraduate seats. COVID. Now, all of you know the graph, there's nothing new to tell you. And September 2020 is considered to be the peak of the first wave. 17th of September 2020 is the precise date when the first wave peaked. And in May 2021, sometime around 14th or 15th May 2021, is considered to be the peak of the second wave, which at a very, very conservative estimate was about 4 times bigger than the first wave. Now, COVID being, I think there is more or less medical consensus, sort of virological consensus that it is essentially a man-made disaster through the gain of function research. But what we have not got an insight into is that why was it released into the community in that particular time when it was? I think that part of the thriller is yet to be discussed. And I'm expecting some publications in the very near future that why were the lab doors open in September, October 2019? Why not earlier and why not later? Anyway, I'm sure a part of the serial, lot of the story remains to be told. There has been limited publications about what has been the collateral health damage from the outbreak of COVID in different parts of the world. As far as, kind of global or panoramic estimates are concerned, European Heart Journal in February of this year, I think this is a Danish work, and this Danish paper tells us that there has been overall about 5% excess cardiovascular mortality. But we have to remember that they are essentially looking at Europe. Now, if you invert the slide of the case incidence, what we saw a little earlier, you just invert it, you get some idea what effect it has on the kind of clinical and procedural front. But it is not a mirror inversion. The reason it is not a mirror inversion is the first wave, though it was 4 times smaller, had about 1.5 times more effect. Because the lockdown in India, it is now popularly believed that the lockdown in India was probably early by a year. Instead of March 2020, it should have perhaps come in March 2021. That's a different story. Now, the first wave, being a very stringent and very national lockdown for 78 days, it completely flattened the patient's access to sort of any cardiac care, cardiological, cardiac surgical, and this is primarily based on a survey which is done in the All India Institute, and I think All India Institute probably admits that they had a 90% reduction of their activity in that 78 days period. I think there were many places who literally shut shop and did nothing. When we come to the second wave, because second wave by that time the entire national game plan had changed. We did not have any national lockdown. 30 states of India had 35 different plans of how to mitigate the second wave. It was utter chaos. But what happened was, since it was a fragmented phenomenon, And second wave did not rush through the country in a kind of time linear function, because between the West and the East, you had almost 40 days, 45 days time lag. So different regions were suffering in slightly different times, separated by about a month and a half. And the impact on the clinical activity that we saw was a little less, and it is roughly computed. These are mostly data you're getting from surveys by accountants and economic forums. What kind of data clinicians come up with, we have to wait for that. So it's about 90% during the first wave and around 70% during the second wave. As we just discussed, that I still consider the first lockdown to be completely miscalculated. It was nationwide, synchronous, severe economic effect. But one thing regarding the first lockdown was that perhaps India did not have any excess mortality as far as the first COVID wave was concerned. There was a thumb rule that, by having a lockdown for 78 days, our mean mortality from COVID, even it was 1,500 a day, we were saving a net 1,000 lives from road traffic accidents. The second wave was a different story altogether. It was fragmented, no national lockdowns. There was some activity, but that was really traded off for very high mortality. And both the case incidence and mortality was conservatively about 2.5 times higher during the second wave. Now, almost every hospital I know of, without exception, when we heard the footsteps of the second wave, almost everyone started to get ready by saying that look, we are going to maintain our services. There is no national lockdown this time, so we have to maintain both COVID and non-COVID activities. But friends, all of us have seen the flood in front of our eyes, and we were totally overwhelmed by the magnitude of the calamity. And whatever we planned at the beginning of the onslaught, by the time we came into the heat of the moment, we were completely overtaken by this phenomenon between about April to June 2021. I think that is this, whoever as a healthcare facility stepped into the arena had this unwavering experience between April to June 2021. Now, our experiences will have to be assessed in the background of what is really worrying is COVID or no COVID. India's healthcare infrastructure has literally been growing at a snail's speed. We have about little less than 70,000 hospitals, 43,000 being in the private sector. We have about little less than 19 lakh beds. About 11 to 12 lakhs are again in the private sector. But be it private or public, due to a lot of confusion, the absolute growth rate for a population which is still expanding at more than 1.5% has been pathetically slow. So the bed strength of the infrastructural strength of Indian healthcare remains essentially static. About COVID, the most interesting thing about all this sort of flurry of activities, we being overwhelmed, etc. If you look down each particular state of the country, there are 15 major states in India, 15 smaller states and union territories. I have looked at the clinical care capacity of each and every state, at least during the first wave. And I tell you something, if you look at the stated capacity of every major state in India, right? No state so far has used more than 50 to 60% of what we say is our built-up capacity, is our stated capacity, and that is most confusing. Because when the system, say in North America or United Kingdom or Europe says that we are overwhelmed, what they actually mean to say is they've actually used up at least 80%, if not 90% plus, of their available bed strength. But we got overwhelmed by using less than 60%. And that raises a very serious question that forget about the growth of infrastructure. does the remaining 30 to 40% of the infrastructure, does it actually exist? If it did, then why did we not bring it out into play? Why did we not actually use that infrastructure when time was at hand? You need to have a concept. We carry all these emotive things about private and public and all these things, and much of these dialogue happens to be a wartime dialogue. But at peacetime, you need to have a kind of granular view of what happens in real life. Now, in private sector, 80% of hospitals do not belong to the large corporate networks. Corporate networks are obviously the likes of an Apollo, Fortis, Max, maybe Medanta, Medica in Eastern India, Narayana. So 80% of private hospitals are very alike the MSME sector of the Indian economy. And we have a lot of standalone infrastructure which are outside corporate hospital networks. And these hospitals took a big beating, and about 50% of their top line was shaved off in these two exposures of COVID. And almost each and every institute, without exception, is what you call EBITDA negative. Many of you understand what EBITDA is. EBITDA is basically a profit margin before you calculate tax, interest, so on and so forth. So the top line, which is the total turnover, was completely shaved off, and their profit margins was completely chewed up. And this will seriously affect their ability to survive. Once again, if I analyze down the line that what happens in cardiac procedures in India, you see 75% of all procedures. I'm taking both surgery and interventional cardiology together, happens in the private sector. About 25% happens in the government sector. And 80%, as we just said, 70 to 80% of all private facilities are small to medium scale. They do not belong to the large scale corporate. And 60% of the private, but you see, the private sectors, they may be about 20 to 25%, but 20 to 25% of the corporate hospitals, they control about 60% of the procedure. So a fewer number of corporate networks do a larger percentage of the procedure. Now, before COVID came and swept through our lives as we knew it, there was another disruption happening in India, and this was a non-virological disruption. And this non-virological disruption is that since about the late, say 2019, 2020, because of the competitive populism between the center and the state, the kind of patient breakup, a private sector was seen, changed quite abruptly over a period of year and a half. Because roughly what has happened is OUP means the out-of-pocket payments. The out-of-pocket, the so-called cash-paying patients were about 50%, 40 to 50% of an average hospital. You had a regular corporate and you had a low insurance. And in a matter of less than 18 months, there was a paradigm change in the way the hospitals, what kind of patients the hospital saw. Low insurance expanded tremendously, and that was at the expense of the cash payments and the regular corporates. Now, yes, frankly, I think that means well in the long term for a healthcare of a country. But in the short term, the private hospitals have had a tough time, or are still having a tough time, in trying to cope with this new reality as it is in front of us. So from about 2013, 2014, I mean, not so much in our part of the world, in Eastern India, but especially south of the country, things were changing dramatically because interventional procedures and surgical programs were largely becoming a numbers game. So you had to be very good in having high inventory of moderate or low pain cases. Now, many of us are familiar that of all the predictions that this COVID is going to have in the Indian economy, you have various scenarios from about a slight impact on the economy to a severe impact on the economy. The severe impact is about 8 to 10% shrinkage in our gross GDP. And as it stands at the moment, I think the severe outcome seems very likely. And these are some numbers, those of who are interested in the fiscal performance of hospitals. So what this side basically means that when we come to assess the fiscal impact of COVID on hospital sector in the year 2021, all these numbers you see within brackets, 15 and bracket 10%, what it basically means is hospitals, especially the medium grade hospitals, would be in the red. So they're already pushed into the red with the COVID crisis. And these are more data. I won't bore you. It's rather late in the evening with it. There are a lot of parameters you can look at. You can look at EBITDA, you can look at the interest coverage, you can look at your cash receivable days, the cash position, etc. And the summary is, it's like looking at your mortality statistics, clinical outcome, the fiscal outcome. Basically, you can summarize this slide by saying bad news. That's what it is. Was corona a cushion? A lot of hospitals, especially multi-speciality hospitals, either willingly or forcefully, they were participants in the COVID program. And did the high admission of COVID patients help? Did it help them to see through this sort of roller coaster ride in terms of financial effect? I think once again, the summary answer is no, because there was rate capping in most states. Hospital remains because COVID had a lot of critical care load, lot of pharmacy load, lot of rate capping. There were no procedures. There were no implants. There were no procedures. And that is where the revenue intake of the private sector depends to a large extent. And at the end of the day, it was a lot of hard work, a lot of people, a lot of casualties, 1,500 medical lives lost at the end of it. But the private hospitals continue to remain in the financial doldrum. There were few hospitals who managed to tide it over better. And the very few hospitals, I've mentioned a few of them over here, because they got involved in the ECMO program. The ECMO program was very challenging, back-breaking, high disposable costs, high manpower, intense workload. We probably run in Medica, Kolkata today, the largest ECMO program of Asia, and that is completely managed by cardiac critical care. There was KIMS Hyderabad, MGM, Medanta, Priti Vinayak, Amri Kolkata, Apollo Kolkata, and these hospitals, with a lot of hard work, did make up from some of the Were we the only country in the world which had the downturn from COVID? Not really. This is a financial snapshot of what's happening in the United States, that overall cardiac practices in the United States are going through exactly the same problem. And Europe is a different kettle of fish because they have only expenditure in their healthcare system. They're not very revenue conscious. We will get to know of it when Germany releases their data. Not a lot of German data is available right now. It made a big difference to training as well. And I found out this paper, which Dr. Guha, Shantanuda is one of the co-authors, its impact on cardiovascular training and care. If you haven't read it, have a read of it. Professor Yadav and Dr. Guha, I think, are also mentioned over here. And they make a very important point in this paper. Cardiac surgery in India was struggling but surviving. And the reason cardiac surgery still had a comparative growth rate was that we had very low population penetration. And as the population accessibility to cardiac surgery was improving through the medium paying and the low paying schemes, India was one of the fewest geographies in the world which showed increase in cardiac surgery numbers with better access to healthcare. But again, cardiac surgery took a tremendous hit during this. I think the graphs, you can superimpose the graphs for cardiac surgery and cardiology, but the impact during both the waves height of both the waves in cardiac surgery was far worse. And the cardiac surgery personnel, the doctors who were involved in cardiac surgical practices, took a big hit, I think more so than cardiology, because if you compare numbers for numbers, a far larger proportion of surgeons and surgical teams are involved in cardiac surgical programs in a fee-for-service model. I think they took a back-breaking hit during both these experiences. And all this turmoil was happening. You know, I've discussed this in my book at length. When there is, and 2019 was not a very happy year. 2018, 2019 was not a happy year, especially the second spell of the NDA government, because there was a lot of confusion about who's controlling healthcare. There was ever-changing policy. There were 10 states in India trying to usher in public healthcare. The central government wanted to usher in private healthcare. There were high aspirations, budgets were inadequate, and doctors across the country, there was severe increase all across the country in public protests and outrage against doctors, because doctors were actually carrying the cross of the national confusion. So even at the height of the pandemic, forget about what happened before, forget about all we have heard about 1% of GDP being spent on healthcare and all that. How serious are we about healthcare, even when the fire is fierce? Even at the height of the pandemic, we have all seen across our television screens the finance minister coming and announcing various tranches of economic stimulus, about 50,000 crores or 40,000 crores. And I did a rough maths, and my rough maths told me that about 5% of all the economic stimulus that was given to the national economy in terms of the pandemic came to healthcare. So that is how serious we are as a country, as a government on healthcare. 5% of assistance came to healthcare at the height of a pandemic. Will private healthcare survive a third wave? It makes no difference to government facilities, because they are largely financially unaccountable. They will go on come wind or high water. We don't know really that what a third wave will look like. I was just listening to a lot of experts, data analysts, data modelers all over the world. Some people are predicting a blip, some people are predicting a bump, and the others are saying no wave will come. We need a lot more local data and local intervention. The vaccination gap between promises and reality is becoming very worrying. But God bless us, if we do have a mammoth third wave, then this will be a crippling blow to standalone hospitals. I'm advising 3 such hospitals at this point of time. And I tell you from experience that apart from a kind of larger chain with whom I'm engaged most of my times, I'll tell you, the medium scale enterprises are having a tough time to survive. And if we have anything which is even half the magnitude, the impact that the second wave had, I think 10% of the smaller or the medium scale interventional units will become very, very, very vulnerable. The recovery of the economy of a country, the activity of a country in general, and the world overall depends upon, at this time, there is only one variable, and that variable is the efficiency of the vaccination program. We are not doing brilliantly, we are doing something, we are not doing brilliantly. We are going at about 50% of our desired rate. And these are the 3 kind of projections. The upper green line of recovery is, should you go hammer and tongs with your vaccination? We have an example in front of us. Rather, we have 2 examples in front of us. We have Israel and United Kingdom. Israel, United Kingdom is following the green line. They have opened up. They are seeing more cases. They are not seeing increased hospitalization or mortality. And so far, the going is good in those 2 countries. The central projection is where you have a kind of kind of vaccination. Europe probably falls within that line. The Middle East a part of Central Far East may fall over there. And we are afraid that we are following the lower part of trajectory of economic recovery because our vaccination is just at about half. We wanted to do 90 lakhs to 1 crore a day to get us to about 60% population vaccination by July, August. So we've missed the target and we are about half of our speed. So that is a major source of worry. If we have one comfort, it is really a little bit of a sadistic pleasure. The sadistic pleasure is from the fourth Sero survey, because the fourth Sero survey tells us that 50%, 69.8% is the overall antibody prevalence. So probably God has given us a lot of vaccines for free over there. So that may save us a little bit. Time will tell. So for the time being, friends, I think we have to be holding our hands. The larger infrastructures needs to come together and do a lot of caring that will be needed. Otherwise, a lot of the small and medium scale players who are out there in the field will find it very difficult in the months ahead. So in the meantime, let's keep our masks on, pray well and pray hard, because we do not want the unpleasant experiences of another wave yet again. Thank you, and thank you all for the opportunity. Thanks.
Thank you, Dr. Sarkar, for your nice deliberation. Not only the impact of COVID on cardiovascular outcome, also on the economy. You have described nicely in the broader aspect. Just 1 and 2 point to explain. Really, in the COVID period, non-communicable disease management got a setback, because when the COVID pandemic struck India, India was not prepared, and India used all the infrastructure prepared for the non-communicable disease. This is one part. Another part is, in the COVID period, we all physicians, we have observed patients prefer the conservative management because they are afraid to go to the hospital. That you mentioned, the corporate hospital, for any intervention. They prefer Dr. Saab give the medicine, we will stay at the home. So this is the time to analyze what is the outcome of medical therapy versus interventional therapy in a cardiac patient. Because this data, if we do the in-depth analysis, can give a light how much intervention is really needed for the cardiac patients.
No, I think if you allow me one comment, Jyotirmoy, I think that study has to have a third arm. The third arm is no treatment, second arm will be medical management, third arm will be intervention.
Yes.
Because I honestly think, we need to do a lot of soul searching, because many a times, like in West Bengal at this point of time, our policies on public transport is completely faulted. It's completely faulted. We are denying patients at appropriate moment access to healthcare the way they should have. And I think, we cannot pretend. This is not the time to have a study on medical, just say between treatment and no treatment. I think about 80% of people just perish without any treatment, without access to any form of healthcare.
Yes, not only for the transport, all the economic condition, the inaccessibility, fairness for to come to the city areas, all these factors have played a role. So I think in the post-COVID period, we should analyze what is the real outcome, what happened to these patients. Thank you, sir. Thank you.
Kunal, thank you very much for talking on a subject in a different way, a welcome change for all of us. It was an administrative approach, fiscal policy, government policy, failure, not making the expectation fulfill. All these factors are there. But as Jyotirmoy pointed out, to a certain extent, I find another factor is that while the mortality of COVID was around 2 to 4% overall, and the cardiovascular mortality remains high, 10%, 12%, 15, 20%, even then, many of the patients, our patients, they were reluctant to go to the hospital because they might get COVID. So the chest pain patient, they suppress their symptoms. The breathing difficulties, they suppress, and they wanted to stay back home. And that was a very important factor from medical point of view as to why the COVID scenario has changed so miserably in terms of treatment and outcome, because more patients died because of lack or absence of treatment rather than from incomplete treatment because of the fear.
Yes, yes, sir. Yes.
Welcome change, rather, in the words of Anyanda. I will also say this is a welcome change, because we discussed science today. Now we heard something other than science. Thank you for giving the insight. Incidentally, this was the last program of this conference, and we are coming to an end of this UCD 2021. But before I conclude, I need to announce the results of the yesterday's case presentation competition, where All India Institute of Medical Sciences, New Delhi, were the winners, and Sri Chitra Tirunal Institute for Medical Sciences and Technology were the runners-up. And today in the morning, in the quiz competition, again, the All India Institute, New Delhi was the winner, and LPS Medical College, Kanpur, they were the runners-up. So, as every good thing should come
carries
to
all the prizes.
Yeah, the case presentation, there is a cash award of 60,000 for the winners and 45,000 for the runners-up, and for the quiz 50,000 and 30,000.
Right.
So let us conclude this year's UCD, and with a hope that we will be meeting physically rather than virtually in the next year in the UCD 2022. That is our fervent hope, and we really and sincerely wish that we can meet physically and organize the conference in the next year. So, good night.
Thank you, Shantanu. Thank you, Soumitra. Thank you all
Good night.
organizers here for an
And
excellent
goodbye.